Okay, good evening, everyone, and thanks for the program committee for inviting me to speak today, or tonight, I guess. So I'm going to talk about skeletal fragility in type 2 diabetes. To introduce myself to those who don't know me, I'm Jad Sfeir. I'm a junior faculty at Mayo Clinic in Rochester. So my goal today is to review the epidemiology of fractures and bone density in type 2 diabetes and look at the clinical risk factors that are specific for this population of patients. We'll evaluate diabetes effect on bone microarchitecture and briefly touch on what are the possible mechanisms behind the increased risk of fracture in type 2 diabetes. So let's start with the type 2 diabetes and the risk of fracture. This is data from the Women Health Initiative that looked at women that had the type 2 diabetes compared to the remainder of the women in that cohort. And as you can see here, after adjustment for age, there was an increased risk of fragility fractures at multiple sites, except the forearm. They were all statistically significant, ranging between 30 and 40% increase compared to general population. And this is local data from Olmsted County here by Joe Melton and colleagues when they looked at both men and women with type 2 diabetes compared to the remainder of the population in Olmsted County. Again, you can see that the standardized incidence ratio was increased in women at most sites except the forearm, which replicates what was seen in the WHI. In men, it was mostly vertebral fracture, but overall, any fracture was also statistically significantly increased in type 2 diabetes. Instead of going through all the studies that looked at that, I'm showing here pooled meta-analyses of studies, and along the years, more and more studies are coming up looking at that. And you can see that hip fracture, any fracture are increased in men and women with type 2 diabetes compared to the general population. And this is the most recent meta-analysis that I was able to find dating from 2019, just a year ago. It looked at 25 studies. This is the largest we've had to date. The overall risk of fracture was 1.22 compared to the general population. But if you look at the breakdown, again, forearm is showing as not significantly increased like we've seen before. Interestingly, though, vertebral fracture in this pooled analysis was not statistically significantly increased as opposed to other individual studies. But again, the overall risk of fracture was increased in this population. So there's no doubt that we have an increase in that risk. But what's most interesting is that patients with type 2 diabetes have actually an increased risk of fracture at a higher BMD compared to what we've used to in the general population. So looking at this data from Ann Schwartz, and this is pooled data from 3 large cohorts, the SOF, the Mr. Oz, and the Health ABC. So looking at all 3 cohorts, which was about 17,000 patients, 2,000 of whom had diabetes. They compared diabetes with insulin, diabetes without insulin, and then the rest of the cohort. And you can see that at any T-score, there is a increased risk of fracture compared to the same T-score in the general population. So patients with diabetes, men and women, are fracturing at a higher T-score. If you look at the -2.5, which is the magic number that we use here to define osteoporosis or at least treatment, if you extrapolate that same risk that is seen in the general population to those in the with diabetes, this translates to -2. So what the risk of, this is hip fracture here, the risk of hip fracture at -2.5 in the general population translates to the same risk at -2 T-score at the femoral neck for patients with type 2 diabetes. Now, mind you, though, that the overall risk in this group was higher than what we're used to see. -2.5 here was closer to 15% risk of fracture, but this is a specialized population that they were looking into. Nonetheless, compared to the patients without diabetes, the diabetic population had an increased risk. The same data was also shown for vertebral fracture, but I'm not showing that here. Another risk factor other than BMD is actually A1C itself. And here we're looking at different A1C levels that are listed up here. And you can see that there is an incremental increase in the risk of fracture over time, depending on the A1C. It increases with the increase in A1C. And looking at the same data in a different way, if we compare those who have an A1C between 6 and 7%, considering them as the reference group, you can see that there is an incremental increase in the age and gender adjusted risk of hip fracture, most significant when A1C was greater than 9% and even more greater than 10%. So as I've said, the bone density in these patients are increased and they fracture at a higher bone density. This is data from our own group here, looking at bone density in patients with type 2 diabetes and in controls. And you can see that across the board, total hip radius and spine bone density were higher in type 2 diabetes compared to the controls. After adjusting for BMI, there was a attenuation of the increment of bone density, but it did not completely obliterate that, indicating that weight alone explains only part of the increase in BMD, but not the entire story. Looking at turnover markers in the same cohort that we looked into, you can see that type 2 diabetes compared to control is a low bone turnover state with a decrease in P1NP, decrease in CTX, and it remains consistent even after adjustment for weight alone or for BMI. What about FRAX? Can we estimate the risk of fracture using FRAX if this is different than the general population? It turns out that no, FRAX does not estimate the risk of fracture in type 2 diabetes as well as it does in other population or the general population. Again, going back to the short study that looked at the Mr. Oz, SOF, and Health ABC cohorts, again, FRAX did not even predict the hip fracture of the general group, and that's probably because that cohort is a specialized osteoporosis cohort. But comparing the diabetes to the remainder of the cohort, there was a bigger discrepancy from what's expected or predicted by FRAX compared to the actual risk, both men and women. There seems to be a higher risk with those on insulin compared to those, especially men on insulin, but this is likely a confounder rather than a problem by itself. So looking more at the general population, so this is a population-based cohort from the Manitoba, from Bill Leslie group. And you can see that comparing, this is about 50,000 total cohort and 5,000 of them had diabetes. Comparing those with diabetes in gray to the general population, the remainder of the population without diabetes in black, you can see that what's predicted by FRAX is estimates well what's in the general population. However, there is a shift upwards, a higher risk than what's estimated by FRAX to the actual risk, both for major osteoporotic fracture and for hip fracture in both men and women. So FRAX itself cannot really estimate well the risk of fracture. So what can we do to fix that? Bill Leslie looking at the Manitoba cohort and working with John Keynes on this, they tried to see how can we modify FRAX in order to better estimate the risk of fracture. And they tried multiple adjustments for that. So if you look at, this is for major osteoporotic fracture, if they calculate the FRAX unadjusted as it is significantly different from predicted value compared to the actual value. So it was statistically very significant. Our goal here is to bring it down to 0 so that there is no difference between what's predicted and what the actual risk is. And turns out that if they use rheumatoid arthritis in the FRAX calculator, it brought this down to 0. So using RA estimates very well within the FRAX major osteoporotic fractures. Using TBS alone without the RA corrected it, not completely, but it approximated it better. decreasing the t-score by 0.5, and this 0.5 came from what I showed you earlier, this shift between -2.5 and -2. So using that, they tried to lower the t-score by 0.5. It improved it, but did not do it all that well, completely down to 0. But if they raised the age of the patient when we're calculating the FRAX by 10 years, it did bring it down to 0. So to better estimate MOF in FRAX, we can either use RA or increase the age of the patient by 10. What about hip fracture? It turns out that none of these did completely correct for the discrepancy. However, it seems that the best is increasing the age by 10 years. So only by adjusting for that, we can better approximate hip fracture risk and, as we just saw, MOF. RA, although it did for MOF, it did not correct for the hip fracture. So that's probably the best thing we can do for adjusting FRAX when we have a patient, especially if we have a patient who has both diabetes and rheumatoid arthritis. You cannot click it twice. So you can actually raise the age by 10. What about the impact of diabetes medications on bone? This is data that's collected by the IOF working group, but I updated it based on more recent data in the past 2 years since publication. Kind of bottom line here, TZDs are the worst. They decrease BMD, they increase risk of fracture. There is no doubt about that. Sulfonylureas, we don't have much data on BMD. It seems that they are neutral. They do not necessarily increase the risk of fracture, although in some reports it is showing that some sulfonylureas do increase the risk of fracture. Metformin seems to be either neutral or in fact a little protective. GLP-1, they seem to have maybe some beneficial impact on bone density, not necessarily increase in risk of fracture. However, liraglutide in one study, it showed that it might actually decrease the risk of fracture and be protective. DPP-4 inhibitors, no data on BMD, but there is either neutral or improvement in fracture risk. SGLT2s, we have individual data. Most of it comes from canagliflozin, but it could be a class effect that there is maybe an increased risk of fracture, although the remainder of the data is controversial so far. And then insulin, as I said earlier, patients on insulin seem to be insulin seems to increase the risk of fracture. They fracture higher, but this could be a confounder in most of the studies, as patients on insulin seem to have a longer duration of diabetes, a higher A1C, both of which are higher risk for fractures in type 2 diabetes. I'm not going to go over this, but I included it here. So if you want to look at where these medications could impact the bone at the cellular level in order to see what the effect that we're seeing, this would be a good review to look at. So to summarize this first part, for a given T-score, as I said, patients with type 2 diabetes have increased risk of fracture. Bone density is either preserved or even increased. What the additional risk factors that are specific to this population are longer duration of diabetes, worse A1C, some diabetes medications. And then in terms of FRAX adjustment, you have options. Increasing the age by 10 seems to be the best option here. Looking at quickly at the bone microarchitecture in these patients. So this is looking at HRPQ-CT of the distal tibia and the controls, and then the 3D modulation of that. Patients with diabetes without fracture, you can see that the cortex here, there is more porosity, increased cortical porosity, maybe even thinning of the cortex. The green that you see here is the increased porosity in the cortex. And you notice that with fracture, which means that even more fragility, you have a significant amount of cortical porosity, but the trabeculation is also significantly impacted compared to controls. And looking at our own data using a technique called the OSTEOPROBE microindentation technique, which basically, as you see in the figure here, the patient has this probe in the shaft of the tibia with applying a constant pressure causing some microindentation and seeing how much the bone can resist that indentation. This is a pilot study, 30 diabetics compared to 30 controls that we looked at here. They were well matched for age and height, but BMI weight was higher in the type 2 as expected. They had a higher A1C and a decreased turnover of the bone. And if you look at that bone material strength index, which comes out of that probe that I showed, there is a significant 12% decrease even after adjustments for weight, meaning that the mechanical properties of the bone are impacted. So the second part tells us that we know that microarchitecture and mechanical properties of the bone are impacted in type 2 diabetes compared to controls. And then briefly touching on what are the causes of this discrepancy, one thing that comes up frequently is advanced glycated end products, or AGEs. What AGEs are glycation of proteins that are present either in tissue or in circulation that occurs non-enzymatically, just with time and with exposure to sugars and exposure to oxidative stress. There will be glycation of these proteins that can become more and more permanent. And it seems that collagen type 1, which is present in both the bone and the skin, can be significantly impacted by these and produce AGEs. The most famous of them is pentosidine and CML. The reason I'm mentioning the skin is because the way we measure AGEs is not by directly measuring those compounds, because they are very unstable and hard to measure outside of research assays. But we can use this machine which looks at the fluorescence of the skin. Having the patient put their forearm, it will tell us what is the level of AGEs compared to normative data. This is data from the Columbia group. They looked at 16 diabetics compared to control, and they saw that the AGEs were negatively correlated with the BMSI, whereas that's not the case in controls. Looking at our own data here in Rochester, we compared 171 diabetics compared to 100 controls, both postmenopausal women or men greater than 50, with appropriate exclusion of secondary causes for bone disease, well matched for age and sex, with an average A1C of 7.8%. You can see that although the BMSI was not, in this larger cohort, was not significantly different, AGEs were higher in diabetes compared to controls. DEXA was significantly higher as expected. And then looking at those skin AGEs, they did also correlate with the BMSI negatively in type 2 diabetes, much more than they did in controls. Cortical porosity, as I mentioned earlier, is increased in this group, and we were able to see in our cohort that the cortical porosity actually corresponded with lower transcutaneous pressure of oxygen, TCPO2, which indicates microvascular and decreased microvascular complication and decreased perfusion to the periphery, meaning that it could be explained, the cortical porosity could be explained by vascular issues that are happening distally in these patients. I just wanted to leave you with this kind of working hypothesis of, despite seeing an increased bone density in patients that is supposed to be protective for fracture in type 2 diabetes, we are seeing a decreased low bone turnover that is negatively impacting, increasing the risk of fracture. This low bone turnover could be mediated, at least in part, by those increased AGEs, decreasing the bone material properties leading to fracture. Complications, including microvascular complications, causing increase in cortical porosity, again impacting fracture negatively. But also outside the bone, we have increased risk of falls with neuropathy, retinopathy. Medications, as I mentioned earlier, that can increase the risk of falls also impact the risk of fracture. Data that I did not show today that we're working on, we show that in mouse models, but we're now looking in human models, that there is aging represented by a mechanism called cellular senescence that might have an interplay here, but this is data to come later. So maybe in a year or two, I'll come back and talk about this to this group. And then this is just included for your reference, how to treat patients with diabetes. This is again from the IOF working group. A little complicated. They recommend treatment for osteoporosis if someone with type 2 has a hip vertebral fracture. If they have a vertebral fracture on imaging, even if not clinical, they recommend if T-score is -2, not -2.5. Or if after adjusting for diabetes in the FRAX, the country-specific thresholds are achieved. Otherwise, close monitoring of these patients with clinical assessment and repeating DEXA every 2 years. And this is, again, for your reference, which medications out of our armamentarium in osteoporosis showed to be effective specifically in type 2 diabetes. Not that many, but you can refer to that. It seems that bisphosphonates do work. Denosumab definitely improves that. Teriparatide, abaloparatide, we have data on that. Maybe even impact on glucose itself, glucose metabolism itself. Denosumab is showing maybe at least in mouse data that there could be improvement in A1C and insulin sensitivity. Same for romosozumab. Teriparatide and abaloparatide and human data are showing only in one study, teriparatide showed increase in glucose, decrease in tolerance, but this was not seen in the larger clinical trials. And I thank you for your time and happy to answer any questions.
Excellent talk. Thank you very, very much. We do have a few questions. The first is, to what degree does peripheral neuropathy and falling contribute to the higher risk of fracture in type 2 diabetes?
Yeah, very, very good question. It does increase the risk. So in population studies, they show that falls are increased in the population, but most of these are observational data that we cannot make definite conclusions from. But it seems that this does not explain the entire picture. So after correcting for these falls or excluding patients who have neuropathy, the risk of fracture is still increased. But that certainly is one part. And if you notice in the graph that I showed, kind of a summary, that this is a major part of why patients with diabetes do have increased risk. And it could also explain why with longer duration of diabetes and those who have worse control also do have increased risk of falls and fractures.
Great. Dr. Shaker has a question.
So, Jad, that was a great talk. I really enjoyed it. I have a comment and a question. The Bill Leslie data with how to best adjust FRAX. After reading it, I decided that the kind of best easy thing to do was just to click RA, of course, in a patient who doesn't have RA. And my reason is that I think there's a problem with adding age in older patients. If you get to about 75 and you add 10 years, you're then reducing the risk because of the competing death, which happens with FRAX. So I worry a little bit about adding age, particularly in older people. That's just a comment. The question I have is, you know, diabetics, long-standing diabetics often have this diabetic dermopathy, this tightening of the skin and, you know, the prayer sign and diabetic facies. Is that from AGEs? Does anyone know?
Before I answer that question, which I don't have a good answer for, but in your comment, actually, I agree with you. I do this in my clinic too. I hit RA for those patients because I worry that, I mean, the increase is not linear, the risk increase. So we might be changing that when we add 10 years. I'm not sure if the AGEs have an impact on the skin changes on diabetes. I don't know that data. Sorry.
Thank you.
Okay, one last question. Should we be checking bone turnover markers in patients with diabetes? Also, can you talk about if bone health is impaired in both type 1 and type 2 diabetes? Is it worse in one more than the other?
Thank you. Both very good questions. Let me start actually with the second question. Yes, type 1 diabetes, there is significant data that show that there is increased risk in patients with type 1 diabetes, risk of fractures. possibly even more than what we're seeing in type 2 diabetes. We don't have enough data looking at why we have that. There are in the studies that looked at the mechanistic properties of bone, there seems to be a difference in terms of cellular changes that are happening in type 2 and in the skeleton and type 2 diabetes compared to type 1. So we're not dealing with exactly the same mechanism, but definitely type 1 have an increased risk. And in the meta-analyses, when they group them, it seems that type 1 may be actually worse than type 2 in terms of fracture risk. Going back to the first question, bone turnover markers, I mean, that's a very, very good question, and I don't have a good answer to. We don't even know if we should be checking it in osteoporosis in general to begin with. So I do believe that the role for bone turnover is in the drug holiday for sure, but outside of drug holiday, maybe predicting a response to treatment if you're thinking about what treatment to choose. But that's like these are uncharted territories. So I don't know if we should be checking them in type 2. I don't know what benefit we will get out of that.
Wonderful. Thank you very much. We have no more questions.